Well, good afternoon, everyone. So first I want to thank Jeff and ECRI for inviting me to participate in this very interesting discussion today. By way of background, I'm a medical oncologist. I work now full-time for the American Society of Clinical Oncology. Prior to joining ASCO about 5 years ago, I was on the faculty at the University of Chicago for about 30 years. And so all of my clinical experience is in the academic medical center environment. And I thought I would, and I don't have any slides, and I don't have any disclosures, and I'd like to just sort of talk a little bit and then, hope to engage in some discussion. I was going to divide my initial remarks here really into 3 broad categories. One is sort of a high-level view of what's a day like in the life of an oncologist. The second, issues that can impact oncologists' workflows. And the third is, why do workarounds sometimes develop to manage some of those issues. So just to start off, and I'm not going to, go into gory details, but I think everybody obviously is aware that oncologists manage very complex patients with life-threatening illnesses. Generally speaking, most cancer patients at some point in the course of their care will see multiple specialists. So typically, they'll see a surgeon, they'll see a medical oncologist, they'll see a radiation oncologist, they'll see or have their care influenced by pathologists, by diagnostic and interventional radiologists, and increasingly even by molecular pathologists, genomics experts, and so on. So all of those medical specialists are giving input into the design of the care plan for an individual patient, and the weight of their input may vary at different points along the trajectory of a patient's clinical course. There are, of course, multiple other team members on the cancer care team. We work increasingly now with advanced practice providers, nurse practitioners, and physician assistants. We could not do our work without the highly skilled oncology nurses who staff all the infusion suites around the country. We work closely with pharmacists, with social workers, with genetic counselors, with financial counselors. And so again, all of these are members of the team who may be involved in inputting information into the EHR or extracting information from the EHR in order to do the jobs that they do. We have to also keep in mind that many oncologists practice in multiple care venues. So they may practice in a private doctor's office. They may also see patients in a hospital-based clinic. Of course, they will see patients in a hospital. Many oncology practices have multiple clinical offices that may be distributed throughout a community. And it's not uncommon, of course, that these different venues of care don't share an EHR. It's particularly true where the hospital is on one system and the doctor's office is on another system. And thereby exchange of information is very complicated. And of course, our patients tend to bounce a lot in between hospital and outpatient facility. And then we work, nowadays, this is a good thing in a sense, we work at a time of rapidly changing clinical science. The great news for cancer patients is that the field is anything but static. There are rapid changes, many new drugs, many new biomarkers, and many things for oncologists to have to keep up with. And particularly for the sort of general oncologist, who might see a sarcoma patient 1 minute and a bladder cancer patient the next and a lymphoma patient after that, keeping up with not only contemporary treatment but contemporary workup of their patients is exceedingly difficult these days. And so, a lot of their ability to function relies on having accurate information available to them at the point of care, either through the EHR or through some other mechanism that can provide clinical decision support and guidance to them. So that's sort of what we're dealing with. There are many factors then that impact typical oncologist workflows. At a high level, I think that a big issue that we are grappling with now is that there is a tension that I think exists in oncology and perhaps in other specialties, but certainly in oncology, between typically the payer focus on minimizing variations in care versus where the science is leading us. The science is leading us in cancer care to increasing personalization of care. When you consider that each person's tumor in many ways may be unique, may behave in a unique way, may have a unique natural history, may require a unique treatment plan. So how do we balance this tension of creating a unique treatment plan for each individual person versus the pervasive tendency now to try to want to have everybody on a pathway, minimize variations in care, treat everybody the same way to minimize waste and redundancy and so on. That's a big issue because oncologists feel a little bit caught in the middle there. Beyond that, we face many of the things that most physicians face and most medical specialists face. There's all the required documentation that's been discussed at length so far in this meeting. There are issues surrounding optimizing communication among all of these different members of the healthcare team that we have to communicate with. Again, not all of whom might be on the same EHR, and some will, some won't be. So, sometimes you have to resort to good old-fashioned systems like faxing information from one place to the next. I love the anecdote. So our CEO at ASCO now is Cliff Huddes, who some of you may know Cliff, and he ran the breast cancer service in Memorial Sloan Kettering for many years. And Cliff always likes to tell the anecdote of how, at Memorial, of course, they have New York Hospital across the street. And if a patient was being seen by a doctor in both places have the same EHR, but they still can't communicate to each other. So what would happen would be the docs at Memorial would print information from the EHR, fax it to the docs at New York Hospital who were seeing the same patient, who would then scan it into the EHR system in their facility. Yet they were on the same EHR systems, but they had to resort to still faxing information across the street in order to share information about a common patient. There was mention this morning about patient-reported outcomes, which I think everybody's interested in. One of the things that I don't think there's enough discussion about, frankly, with respect to PROs is what is, in a sense, the back-end management of the patient-reported outcomes. So we can create mechanisms and valid instruments whereby patients report their outcomes into the healthcare team. But what is the healthcare team's responsibility to do with that information when they get it? Is it intended to be used in real time in managing patients? And if it is, what are the workflows that are necessary to set up in the doctor's office so that the information is appropriately flagged, alerts are given when a certain level of urgency is reached, and so on? And what is the impact of patient-reported outcomes on the actual communication between doctors and patients? There's a concern that patients may think that through the PRO system that they've reported to their healthcare team how they're doing, but maybe the doctor doesn't actually have access to that information at the next clinic visit. And there's that actually sets up more of a communication gap than anything else. I mentioned clinical pathways, and clinical pathways are becoming pervasive in oncology, and they're now typically being built into the EHRs. And in many ways, that's a good thing, and doctors are being held accountable for adherence to clinical pathways. A big problem that we face, though, is that there's not a single oncology clinical pathway that is accepted across the country. In fact, there are multiple pathways, and typically each payer determines what pathway they require a patient to follow. So that sets up a situation in the doctor's office where, if they're seeing patients who are covered by multiple payers, they have to comply with multiple pathways, and they have to know which pathway each patient is on in order to be able to comply. And we, just as an anecdote, I mean, we heard a, a very, peculiar situation from, one of our oncologists up in Maine who basically said, in their patient population, they work with multiple payers. They have to comply with 5 different pathway systems. So when a patient comes to the office, they give the patient a baseball cap to wear. And the color of the cap indicates what pathway the patient is supposed to be on. And that's the only way they can keep track of how they're supposed to manage that particular patient. So that just leads me then to make a few remaining remarks about workarounds. There was some discussion earlier about implementation of EHRs, and I don't think we've really given sufficient attention to that. I'll give you one anecdote from my University of Chicago experience where we did a EHR implementation before I left there. So, of course, it's customary for cancer patients to have blood work done in advance of seeing the doctor and potentially getting a chemotherapy treatment on any given day. And sometimes the doctors forget to order the necessary labs that need to be run on the patient. Patient shows up in the clinic, they say, I'm supposed to have labs, there's no lab orders. So for decades at the University of Chicago, the workaround for that was the clinic coordinator paged the doctor said, these are the labs the patient should have. The coordinator filled out the lab slips, sent the patient to the lab, and they got the blood work done. When we did the EHR implementation, whoever was responsible for that and whoever was responsible for assigning privileges for who could do what in the EHR decided that clinic coordinators were not going to have privileges to enter lab orders in the system. So now when the same scenario occurred, patient shows up, no labs, page the doctor says, send the patient for these labs. The clinic coordinator says, I can't do that. I have no mechanism to order the labs. I don't have the privileges to do it. I can't generate a lab slip anymore. So the doctor then has to stop what they're doing, find a computer, log in, enter the orders, and so on and so forth. And that can take up a lot of time. There's no good workaround for that in the way that system was implemented. And frankly, all it did was to add significant delays, because when the patient was delayed getting to the lab, they were delayed in getting the results, they were delayed in seeing the doctor, they were delayed in getting the chemo. Implemented delays in the infusion suite. The whole system went down just because of that. Many EHRs now have these clinical pathways built into them, and many clinical pathways have hard stops where you can't advance to the next point in the pathway unless you have entered all the required information, and sometimes you don't have all the required information at your fingertips. That leads to doctors inventing certain workarounds to get around those issues. Of course, cancer patients may have a unique circumstance that requires that their treatment be, quote, off pathway. These days, a good example is there's a tumor genomic profile that demonstrates a unique mutation that might be susceptible to an off-label treatment that would not be considered to be on pathway. And so again, does the system allow you to implement that particular treatment, and how much extra effort do you have to go through to do that? Oncologists like to spend face time with patients, and there's a tendency now to try to minimize the amount of time that's spent taking care of the record and the pathway, and spend more time actually taking care of the patient. That can create workarounds as well. And finally, oncologists are pretty busy. They have limited time. They have this urgency to get to the next screen in the system. That oftentimes requires them to enter data that may allow them to get to the next screen, but may not actually be precise information. And may not be terribly relevant to the patient's care. An example might be information on the tumor stage. So, as you probably know, we have very precise staging systems in oncology, but frankly, for the medical oncologist, it sort of boils down to, does the patient have localized, potentially curable cancer, or does the patient have metastatic, likely incurable cancer? And the details of the stage are actually less important in the formulation of the treatment plan, and yet you can't advance through the system without putting the stage in. So what happens is people sort of estimate what the stage is and put that in. And then if you're actually trying to do some, study on, the prevalence of different cancer stages in the country, you end up with lots of erroneous information in the EHR. So I will stop there, but I'm looking forward to the rest of the discussion.